Hi, I'm Dolly Vasta, and welcome back to Dolly's World. I'm here today with a good friend, Dr. Edward Magaziner, and he's well known in the field of spinal, sports, and pain management, which, although is brand new, it's really quite old. And I'm going to go directly to the doctor, and we're going to start talking because I have so many things that I want to ask you. And so many things to explain. We have our little friend Sam here that you can show, and we also were down at the surgical center, so we have some things to discuss there. Why do you think that many doctors really have a problem with this? Regular doctors, general doctors.
I mean,
with pain management, the whole theory of pain management.
I think two things. One is education. The newer doctors are getting better education in pain management in medical school. People that trained in the past, the problem of pain wasn't taken as seriously, and also the training in terms of how to treat it wasn't given in medical schools and residencies, so people don't know what to do. Person complains of pain, and it's like, well, take a pill or something like that. But now, times have changed, and there are more things available for people in pain, and people like myself and others, train specifically to help these people, and I think it's an exciting field, actually, right now.
Well, that leads into, it's not really a new field. It's an old one. It goes back to ancient China.
Well, that's true. I mean, they were doing acupuncture for 5,000 years prior to that, and certainly through the years, people have been treating pain. But it's really more in the last 20 to 50 years that I think it's become more of an exact science with the medications that are available and some of the specific treatments that are available that we'll probably get into later on today.
You also said to me at one time that probably between 20 and 50% of the people in this country do experience some kind of chronic pain.
Well, that's true. I mean, back pain is probably one of the most common ailments known to man. Ever since we started walking, and the effects of gravity has had its effects on the body, there have been pains from that, either in the spine or in various joints, usually the hips or the knees or something like that.
What interested you enough about medicine to get into it? Did you always want to be a doctor when you were a kid, run around with a little black satchel, or how did it start? Did you have a mentor?
Actually, I did in a number of ways. I didn't start wanting to be a doctor. I went away to college, and I started out actually as a chemist. And then I realized, that I wanted to do something in the health field, that I like helping people and not just, working in a laboratory. So I entered physical therapy school, and I was a physical therapist for 7 years. And then, after graduation, I was helping people in physical therapy. And then I realized I wanted to do even more than that. I wanted to be able to help the patient, fully. So I went back to medical school, which was another 10-year experience. And the reason I went into medicine is pretty much because I wanted to be able to help people, with all aspects of it, kind of be the, the team, physician who can manage a patient.
Where do most people have problems with their spine? Now, I'm looking at Sam here. And, he doesn't look too healthy to me. He needs to be fleshed out a little. But really, where do people have the most problem?
Well, I would say in the lower back, probably the most common area of pain is either in the sacroiliac joints, down in the pelvis here, or in the lower portion of the spine where you have the discs, these fleshy toned, in the model is the disc. And this area over here are the joints called facet joints of the spine. And these little yellow things that are coming out here are nerve roots. So pretty much you can have a problem anywhere in this area of the lower back depending on which tissue is involved in causing that particular pain problem. In the neck, it's usually in the C5, 6, or 6, 7 area. There's 7 vertebral levels in the cervical spine, and most people that do have problems, it's usually at 5, 6, and 6, 7, because that's where you have your most movement when you're turning your head from side to side and things like that.
Right, okay. Well, now that really leads me into one of the procedures that we watched the other day,
Okay.
which to me was fascinating because, to be honest, and you know this, having been on the other side of this, so to speak, face down, it was interesting to watch standing.
Yes.
Explain a little bit. All right, you were talking about the lower part of the back.
Yes.
And I believe that the patient you were working on, the shots you were giving her, the procedure, what was it exactly? What is that called? What is it used for?
Well, on the particular patient, we are doing an epidural injection. And to do that, to do it well, you need to use fluoroscopy, which is X-ray that is in real time, so you can see what you're doing while you're doing it. And pretty much the patient doesn't feel a thing when we do it. We bring them into the surgical center where we have an anesthesiologist that is putting the patient at rest and sedation, even maybe they're sleeping through the procedure. And we'll give a little anesthetic at the area of the skin so they don't even feel the needle going in, you know, when we start doing the procedure. Then we pick, there's a little space. There's actually a number of places that we would start the injection depending on where the problem was. But in this patient we're working on, we're starting down in the sacral area, down near the coccyx.
Right.
And we pass a needle through that area, and we can watch it under fluoroscopy. Then we place some contrast through the needle so we know that we're in the right location. And then we can pass a catheter or medication through that needle. And in this case, we're passing a catheter up the spine to the area specifically where we know this person has their pain problem. We were able to determine that from other tests that we've done previous to this using MRI or EMG nerve studies and things like that. And once we have the catheter in the right place, then we can you know, inject the proper medication. And I think you'll see on the TV screen here that we're injecting the intravenous dye, and we're injecting cortisone medications and things like that.
How long does that really last? Or is that does that go with each patient? Each patient has a different, I don't know what you would call it, tolerance?
Yeah, it goes with each patient. It depends on how severe the problem is, and it also depends on some of the types of medications that you use. But I've seen patients that maybe after 2 or 3 injections in the right place can feel pain relief for 6 months, and there have been patients that may only get a few days of pain relief, depending on how bad their problem is. These injections that we do, are not a miracle for everybody. Some people need other kinds of treatments, or maybe in some cases they do need surgery too.
I thought it would be very interesting if we had a couple of Dr. Magaziner's patients and talk to them and just see how they felt about some of these procedures they've had. And the first one I'm going to talk to is George Demetrio.
Demetrio, yes.
Ah, I got it right.
Yes, you did.
And you're a hairstylist and,
Yes, I am.
and from Milltown.
Yes, I am.
And what was the problem? I believe from what I read that you had a bad back.
Yeah, from what I've been told, there are quite a few herniations in my discs and so on. And,
It's like welcome to the club.
Yeah, yeah. This part of America, I guess.
Yes. But what made you want to go to pain management in particular?
Severe pain will make you do anything. If
Well-
they tell you to stay on your head and it'll solve the problem, you go. And somebody had suggested pain management. I looked in the yellow pages, saw Dr. Magaziner's name. And then I called my family physician, asked him if he had known about him, and he said yes, he was very good. And we started back there, I guess it was a couple of years ago. And I've had several procedures with the doctor.
You had a epidural and
Epidural, yeah.
yeah, and the prolotherapy.
Yeah. And it seems to have worked pretty good. The arthritic part, I feel that when the weather changes, of course, I've gone back to the gym and lost some weight. That also helps a lot. But I got a lot of relief from the last procedure.
Are you happy you went?
Oh, absolutely, because the other alternative was surgery, and that there's no guarantee with that. And quite frankly, a little nervous about surgery, even with the best of doctors.
Well, thank you so much for stopping by, George.
You're quite
I
welcome.
appreciate you giving us your time.
Thank you.
And keep well.
I hope so.
My next guest is Joe Guzzo, and you're from the New York Sports Club.
That I am.
And I hear you had problems with your wrists and your arms.
Wrist, shoulders, and also the tricep tendon from doing a lot of overhead work.
Overhead work.
When I originally hurt this, the wrist, I went to an orthopedic doctor, and right away he says, we can correct that with the surgery, the arthroscopic surgery. And I, like George, am very apprehensive about surgery. So I happened to read an article in a men's fitness magazine about prolotherapy. Sent away for the book, read the book.
Which mentions Dr. Magaziner.
Exactly. In the back of the book, it listed many doctors, but there are only, I think, 2 in New Jersey that did this procedure, and one of them happened to be Dr. Magaziner, who fortunately was 2 minutes away from my house down the road. So I made an appointment to go over there, and I've been going there for about 3 years. The wrist, I would say, is about almost 100%. I'm back to where I was years ago with the amount of weight I'm lifting. A few procedures in my rotator cuff on my shoulders hasn't bothered me since. And we're still in the process of working on my medial epicondyle, the funny bone, and the tricep.
Which isn't too funny when it hurts.
You're
Well, thank you so much, Joe, for coming.
welcome, Dolly.
You do a lot of different kinds of treatments.
Yes,
So what
that's
else
true.
do you do? I know you do prolo,
Yes. Yes, that's prolotherapy.
prolotherapy.
Yeah.
Well, we in the trade, you know, we just throw but what is that used for, you know, primarily?
Prolotherapy is a really fascinating treatment. I'm glad that I was able to study in this treatment. I've been doing it for about 7 years. And it's a regenerative treatment, a regenerative technology. And basically what we're doing is we're injecting medication which stimulates growth factors in the tissue. And we can take people that have had chronic sprains of, say, the neck or the lower back, or of the hip, or of the knees, or the ankles, or tennis elbow, or problems in the shoulder. And we're actually able to grow new ligament and improve the strength of their joint capsules to take away the effects of chronic sprains and strains and tendonitis and things like that. And it works on the same healing principles that if you cut your skin or you break a bone, the body has the ability to heal itself. But only if the growth factors are released in the initial stages can the body go through that process in 6 weeks or so to heal itself. Now, the beautiful thing about prolotherapy is that you can stimulate that healing process over and over and over again until you can make that tissue strong enough to be able to sustain the stresses. Basically, we're fooling the body with prolotherapy. We know that if you injure yourself, the body has a remarkable ability to heal itself. If you cut your skin, it heals. If you break a bone and you set it properly, it heals. If you have heart surgery and they put a few stitches in there and a few wires, miraculously the tissues come together again. But after each one of these incidences, isn't the body painful after surgery or after an injury? And what we do is we create a local chemical type of injury with these medications, and the body thinks it's really been injured when it hasn't, but it sends the same growth factors and cells in the body to bear on that area to create healing to occur.
It really is its own little miracle.
Yes, it is.
When you think about it, and having been part of one of those for a while, and having had it work, I can really attest to part of my body anyway. One of the things that you mentioned to me at one point was selective spinal injections. Now, what does the word selective in that mean?
What that means is you can pinpoint, excuse the pun, with the needle exactly where you're putting the medications. And the beauty of selective spinal injections, and I think this is the crux of pain management. In the past, when people had back pain, they would go to their doctor and say, "Doc, I got back pain." The doctor would say, "Oh, your diagnosis is lumbago." He wouldn't know what's going on with them unless it was a big disc that was seen on x-ray or something like that. And they would throw some medications at it, or put some heat on it or something like that. With selective spinal injections and the use of the diagnostic equipment that we have, such as MRI and nerve testing, we can literally find out which tissue in that person's body is causing their pain. We term it the pain generator. And if you can find out where the pain is coming from and which portion of the back, then you can direct a specific treatment to that area. And that's why we use selective spinal injections in the diagnosis as well as the treatment.
I have often, in my past, with my back history, referred to my team who have worked with me.
That's true.
And on me. And why don't you explain that? Because that's a big part of pain management.
That's true.
It isn't just the pills, and it isn't just
Right.
shots. It's an entire picture.
That's very true. I think from my background as a physical therapist and a physiatrist, we're all taught how to work in a team approach. We have physical therapists that we work with. We have surgeons that we work with, neurologists that we work with. We have psychologists and social workers, because pain is such a diffuse problem. It can be anywhere in the body. I mean, no one doctor can do everything. No one can have training for everything. And no one doctor has enough time to do everything. So we work in a team approach. I think that the physician, such as a pain management expert or physiatrist, needs to interview the patient, find out exactly what the problem is with that person, and then set out a good, effective treatment plan in terms of how to deal with it. And in our practice, we try to do the most conservative things first. So we might deal with physical therapy and acupuncture treatments or with medications. And then a lot of times we don't even do the interventional treatments until other things aren't working or we have to do them.
Pain medication.
Yes.
We were laughing about that the other day. Because every time I have heard something on television of all the codeines and all the different, what is the word that I'm looking for?
OxyContin.
It's all the little pieces of codeine, the different products.
Yes.
They seem to come up that about how illegal and so on and so forth this is.
Yeah, well, unfortunately, there have been some bad press on a few medications in the media lately, and
Oxycodone and,
right.
and hydrocodone and all those.
That's right. I think the general thought is anything, if you put it into a person who wants to abuse something, is going to abuse it. You can take a kid who's going to, take some spray and he's going to inhale spray, or he's going to take some glue, he's going to inhale glue. Certainly if there's medications in mom and dad's closet that can be abused, they're going to use that too. But we can't lose the sight of the fact that pain medications for someone who's truly suffering in chronic pain can be a godsend for that patient. And the better the medication, the more, I guess, abuse potential it can have in the wrong hands. And OxyContin, unfortunately, got a lot of bad press, but it's been a godsend in terms of medication in this last 5 years, I think, since it's come out for people that have chronic pain, whether it's from cancer or back pain or nerve pain or something like that.
Does your treatment of someone who is suffering from cancer really that much different from someone that comes in with, say, chronic back pain?
Yes, it is. There's significant differences. Cancer pain is often treated by the oncologist. They use chemotherapy and radiation therapies to shrink things, shrink tumors and things like that. And pain medications are used on top of those other interventions to decrease their pain. For back pain and other kind of mechanical problems, we actually can go in and fix some of those structures and take away the pain from some of those structures, using different methods.
Well, you also handle sports pain.
This is true.
How does that differ?
Well,
your patient differs. First of all, your patient is probably younger.
Yeah, yes and no. We take care of people that have had cumulative injuries with their knees or their shoulders, maybe related to sports through the years, or kind of acute or chronic injuries from tennis players or racquetball players, in their hands, wrists, or shoulders, or whatever. And we use a lot of the same technologies to take care of these injuries. We use physical therapy and various kinds of manual therapies. And some of those injections we talked about before, especially the prolotherapy, can be fantastic in terms of correcting these problems because unlike cortisone, which I do also use, when need arises, the prolotherapy actually can make the problem just about go away, or at least control it with very minimal effort.
Now, I have also been hearing a lot about Botox,
Yes.
which was originally used to plump up the lip section. Where does it fit into the back? Now, there are two of them, from what I understand. There is a block that is done with Botox.
Well, Botox came about probably
Explain what Botox is, really.
Botox is really short for botulism toxin. Whoa, that sounds scary, right? But they've pretty much purified it, and we're using it for good in this case. I mean, there's lots of medications in medical science that can be used as a toxin, or it could be used for something good. And what Botox does is when you inject it into a muscle, it relaxes that muscle. Because it goes right to the heart of the muscle where the nerve goes into the muscle, and it can knock out that motor fiber for up to 6 months at a time. And if you have a very bad muscle spasm, for example, or if you have spasticity from, we use it on people that may have had a stroke or some kind of cerebral injury, where their arms are spastic, you can use Botox to relax those muscles for long periods of time. So. We found it very helpful in I guess the chronic patients, have the muscle spasms that don't go away with trigger point injections and physical therapy and massage therapy. Like I said, we always try the other conservative things first.
And then go to the heavy duty
Exactly,
stuff.
exactly.
What other kind of shots do you give besides the Prolo and all the ones we have discussed so far?
Well, there's trigger point injections, and they've been around for over 50 years. Hans Kraus was one of the pioneers in that area. Janet Travell was a pioneer in that area. And they actually were the physicians for President Kennedy. A lot of people don't know that he had a back injury, and they took care of him using trigger point injections. And a lot of pains in the muscles, whether it's in the neck or the back or in the arms or legs, you can't see these pains on x-rays. Doctors, unless you can feel the spasm in the knots, you might not even realize they're there. And when these people don't get better with massage therapy and physical therapy trying to break up these spasms, very simply trigger point injections into the muscle, which are a fairly painless situation because you're injecting an anesthetic into the area.
They're very fast, too.
And it's fast in terms of getting results quickly. You can relax the muscles and break up the muscle spasm. And that's one of the types of injections that we do. I also do some of those other selective spinal injections where we do nerve blocks. We go transforaminally and inject these nerves over here for someone who might have a radiculopathy. We go in instead
Which is ridiculous.
Right. in the prior procedure, we had done an epidural injection down here, but if a person has a radiculopathy, we can pass a little medication right around this nerve over here. And there's other nerve blocks that can be done on various nerves in the body where people have, different pain problems.
What do you see ahead for this medicine, this field of pain management?
Well,
It's really in its infancy.
It really is, and I'd say in the next 10 years we're going to see a lot of, a lot more education. It's going to be available to a lot more people, and we're going to see improvement in this technology that we've talked about today. But for the future of pain management, I really see great things, just as I see great things in other portions of medicine. And I think the future is in regenerative technologies. I think that we're in a wonderful time now in history where scientists have mapped out the human genome, and we can actually look at what causes and what helps things and what makes things grow in the body. And I look for the time probably within the next 10 years where we're going to be able to inject growth factors to repair arthritic knees or improve or repair cartilage and the growth factors that cause regeneration for ligaments and muscle and things like that. I mean, they're even talking about growing knees, cloning knees, in a test tube environment, and instead of putting metal and plastic in the future, where they'll be able to put in a new hip where the person won't even reject, instead of the artificial hips. I also look for a future where we're going to have medications that don't have side effects, where they're going to be made so specific that it's going to match the natural pain relievers, such as the endorphins that we have in our bodies, circulating now, but just not in enough supply to knock out a bad pain problem. We'll be able to give a person their own natural endorphins, and they won't have even side effects for decreasing pain. So I think we're entering a good portion of our history here for treatment of pain problems.
And you seem very excited about being a part of it.
Yes, I am.
Well, our time is running out.
Okay.
And I wanted to thank you for coming. I hope we covered a lot of stuff. One of the places I'd like to thank, though, before we do sign off, is the Surgical Center here in East Brunswick. It really is, and this is a personal plug. I wasn't asked to do this, but I've been there many times, and it is a surgical center that is small but beautifully equipped, and their nursing staff is just one of the most caring and loving staffs I have ever been used to. And it's my personal thanks to them when they're watching this, and I'm sure they will be, because they're just great.
Yeah, I've been working there for 7 years, and I'm very happy there.
I wish more things were done, and probably so do they, because they are a part of Robert Woods now.
Yes, that's true.
Yeah, a satellite of Robert Woods. So listen, think about it. Okay, well, again, thank you so much.
You're welcome. It was a pleasure being here.
I'll see you next month, and in the meantime, take care.